Hello, everyone, and welcome to the ICUDDR virtual conference, Sustaining and Adapting Addiction Science to Virtual Realities. My name is Jessica Keene, and I will be the moderator for this session. We're really glad that you were able to join us today. Please submit any questions that you have for the presenters for the Q&A at the end of the session via the Zoom chat. First, I would like to welcome Yulia Yachnik. Yulia will be talking about the ITTC in Ukraine, and Yulia is joining us from the Institute of Psychiatry of the Taras Shevchenko National University of Kyiv.
Thank you. My name is Yulia, and by my background, I'm a medical doctor and clinical psychologist, and I work as a research associate in the Institute of Psychiatry at the Taras Shevchenko National University of Kyiv, and also I'm ITTC Ukraine project coordinator. So I'm here glad to present ITTC Ukraine experience, and this center in Ukraine is a unique collaboration between two universities, University California San Diego Department of Psychiatry and Taras Shevchenko National University of Kyiv Institute of Psychiatry. Ukraine is a country that has a lot of unique features, which also shapes our activities as ITTC center. Except that we have a high prevalence of substance use disorders and high burden of mental health problems, we also have active war going in the country. We have diverse services starting from evidence-based practices and ending up with Soviet inheritance. And we have rapidly changing political background and one of the largest HIV epidemics in Europe. All this shapes our activities as International Technology Transfer Center, and we are aimed to professionalize a workforce in substance use and mental health in Ukraine. Our team consists of Professor Igor Koutsenok, who is our inspirational leader and high professional from University California San Diego, Professor of Psychiatry of the Department of Psychiatry, and Professor Irina Pinchuk, Director of the Institute of Psychiatry of the Taras Shevchenko National University of Kyiv, and she is also co-director of this ITTC project in Ukraine. But except from us, we have a team of national trainers, and I will talk about this team a little bit later. We have advisory board, which consists of national stakeholders and NGOs, representatives, and opinion leaders. And this is actually our first lesson learned, that no changes can be made without support from local stakeholders and organizations and opinion leaders. That's why we have a lot of them in our advisory board, and they provide us with their view of plans, so they're actively involved in planning of ITTC activities, and some of them have quite a different view, different perspectives from ours, and it also enriches our plans and makes the input even more effective. And we are operating on the base of ITTC, Addiction Technology Transfer Center in Ukraine, which was established 3 years ago. So we are taking into account its experience and all that was done during those 3 years. And ITTC started from the needs assessment. And you see this report. So this needs assessment was training needs assessment, also survey of addiction treatment services, and addiction treatment in criminal justice settings. And after this survey, it was possible to to choose the main topics for further dissemination and trainings during next 3 years. So now, in our first year as ITTC, we decided to do the reassessment of needs. So it is in a process now, but we will end up by September. So we arranged the survey of 261 healthcare facilities that are involved in the providing care for substance use disorders. And we also plan focus groups for stakeholders and training providers about training needs. And we hope that this information can help us to prioritize our activities in the next years. As I said, we have a quite powerful resource. It's national trainers. So this is a team of national trainers. Now we have 5 certified national trainers, and they provide a cascading knowledge and skills training on evidence-based practices to all practitioners in all regions of Ukraine. So the idea was, in order to disseminate new knowledge and practices, we had to have the ambassadors, the opinion leaders who will do this in the field. But we faced with the problem that part of the evidence-based practices which work in a lot of countries are not very familiar for Ukraine. And it is very hard to teach something that you don't understand or you don't know how it works. So we decided to arrange not only the training of trainers, but also we arranged a study visit to United States for 10 national trainers from different organizations, and to get them familiar with evidence-based practices and practices that work. And it was really a good idea because now they started to disseminate this knowledge, these practices all over the Ukraine, because all of our national trainers, they are involved in different NGOs and different projects. They have their own budgets. And now they include all these training topics that we teach them into their agendas and into their activities. So the next lesson learned is that we need ambassadors for evidence-based practices. And also, before starting something, we need needs assessment, and needs assessment should shape our activities. So during ITTC years and this first year of ITTC, we decided to focus on sustainability, on how to make sure that these changes will last after the project. So, as I said, so we have 35 certified national trainers, which already provide their activities, their trainings, and they are not dependent from us and from our finances, but we support them and we arrange supervision and extra trainings to have this good team of national trainers. The next that we had translated UTC modules, Universal Treatment Curriculum modules, into Ukrainian. And the first 8 modules of basic series were printed and disseminated all over the universities of Ukraine to the partner universities of ITTC, who decided to change their curriculums according to the UTC curriculums. And in our university, which we are based in, we already implemented 3 UTC-based courses on postgraduate education within this university. So now they are also separate from the ITTC efforts. So they are financed by the university or by clinics who refers specialists to these training courses, or by specialists themselves. These courses are provided by our certified national trainers. Also, we changed the curriculum for medical students, for 4th grade medical students, on psychiatry based on UTC modules. And we partnered the training for faculty members about UTC to change the curriculums and to foster knowledge dissemination. And we translated online course on substance use for veterans because this is one of our target populations. So we translated and we plan to adapt it in the nearest future. So the next lesson learned is that changes should be sustainable, and we should take this in our mind when we plan the activities. So if we are talking about our priorities as ITTC, as I said, we are doing mapping of services and needs assessment right now to be sure that our initiatives are up to date and they will be utilized as it is needed. And I mentioned also about supervision and support of national trainers team. So we organized 10 workshops for national trainers this year and supervisions for our team of national trainers in order to have this active group of opinion leaders and to make connection with them, but also to engage them into communication with each other, into sharing knowledge and their experience. The next challenge, but also the opportunity for us, that it is very hard to implement some new practices or new services in country where have just minimal standards of care or prevention. And this is very tricky question because it requires legal changes. And therefore, we decided to join the committees and work groups on development of addiction rehabilitation standards and addiction prevention initiatives. So this is our next lesson learned. In order to advocate these initiatives, you should be involved in the process of planning on different levels. And of course, it is time and resource consuming and it moves very slowly, but we have hope and inspiration that at the end, we will have these standards adopted in Ukraine. And we believe that this will make the process of providing effective care quite more easy for Ukraine. As far as we will have certified centers and certified practices. But now it's a matter of future. And also this year, Ukraine policymakers turned to addiction prevention topic. In Ukraine, there is only several programs, evidence-based prevention programs that work, and this is like solo initiatives. And we don't have a state strategy on prevention, and all prevention initiatives in Ukraine usually not correspond with evidence-based practices. So now we are promoting evidence-based prevention also, and promoting evidence-based practices on this topic. As for the training activities, we have several priority groups now for this year, but maybe this will be changed after receiving the results of needs assessment and mapping of services. But for now, we have 4 priority groups. The first group is criminal justice settings. So in Ukraine, now we have implementation of MAT treatment into criminal justice settings. And a lot of doctors, a lot of criminal justice specialists received training on MAT, but also in brief interventions and in motivational interviewing. And now we provide support for the comorbid conditions like depression and so on. Another priority group is primary care, and also the priority group is veterans and recovery services. And also a great opportunity for us is networking with different organizations such as ISAP, ICUDDR, and other major organizations. And this is the last lesson learned that I want to share with you, that network is a power that shouldn't be underestimated. And we are very glad that we have these resources and this support from our partners and from our network. And this makes our work easier and more effective. So thank you for this, and thank you for your time. And it was a pleasure to present here.
Thank you, Yulia. Next, I would like to welcome Shamil Wanigaratne. Shamil is a consultant clinical psychologist, head of Training Institute, NRC Abu Dhabi, and an adjunct professor at UAEU Abu Dhabi. Shamil will be discussing the ITTC and the United Arab Emirates.
Morning, good evening, good afternoon, everybody. I assume you're able to hear me. Thank you for the introduction. When Carrie Hopkins asked me to talk about the process of deciding to apply to develop an ITTC in the United Arab Emirates, where Abu Dhabi is one of the states, I was wondering, why did she ask me to do this? And I think I'm beginning to understand the importance of it, because we are slightly different, unique in the sense that most of the ITTCs are universities, academic institutions that are involved in implementation, in implementation work, or trying to cross that barrier. We are essentially an implementation body working towards becoming an academic institution. Unique in the sense that we have science, epidemiology, all sections as part of our institution, if you want to call it that, organization. So in that sense, why an ITTC is an important question, because it might have relevance to other countries in the world who may be in a similar situation and wants to become an ITTC. So I think that's why Carrie asked me to talk about it. Okay, the National Rehabilitation Center Abu Dhabi it's not very old, it's about 18, 19 years old, was established by a presidential decree by the late Sheikh Zayed, founding father of the United Arab Emirates. And there have been a number of mandates, legal steps that has taken place during the last 17, 18 years. And in 2017, we were designated the WHO Collaborative Center. I have had the fortune of being involved in with the National Rehabilitation Center, the NRC, almost from the very beginning. I was working at King's College and at the Maudsley Hospital in London, being a clinical academic. And this was one of the projects that we were asked to establish. So I've been aware of the development and been able to share, not continuously, but with some gaps, but grow up with it. And in 11 years ago, I retired from King's College and Maudsley in the United Kingdom and joined the NRC. So this is the history of the NRC. The pictorial history of the NRC is this. We from a very rented building or series of rented buildings, we built and developed purpose-built campus, which is very large. I'm told even the footprint is bigger than the NYU Abu Dhabi. So it's facility-wise, it's got the capacity in many ways, and the design of it was very forward-thinking. I'm not going to go into treatment, and this is the treatment journey. So we do treatment and lots of other things, as you would have seen in the mandate. And I'm not going to go too much into it, but it's evidence-based, standard, cutting-edge treatment that is available. I think what is of more interest is the other parts of the NRC. In the organogram, there is a training institute, which is above, reporting directly to the Director General, and I am the head of the Training Institute, among other things. And then there is a Public Health and Research Directorate, which has Health Education and Training as a section. And that is the section responsible for prevention work, largely, doing prevention work in school and other areas. Then there is a Research and Studies section. I'm currently the acting head of it. Unfortunately, we had Dr. Ahmed El-Kashif, who was the head of clinical trials at NIDA, who was heading it. He left, and unfortunately, he subsequently passed away. So I'm holding that fort. Then there is the whole communication and public relations thing. Again, prevention campaigns fall in between health education and health communication. And also, most importantly, the surveillance and advocacy, where the epidemiology and also policy work is done. So these are all functions in some ways of a university or different departments of a university, but this is very much a applied clinical implementation service. The timeline, and because Kerry asked me to talk about the process, the timeline was our Director General, His Excellency Dr. Hamad Ghafri, decided that the NRC would benefit to become affiliate ITTC at the time. And he instructed that this process starts. In 2017, as the ISEP conference in Cancun, Mexico, we met with Kerry, Igor, and Laurie, and talked about taking this forward. Then there was a series of memoranda of understanding that was drafted. This might be very boring for people, but this has been a long, drawn-out process where the scope and the work, because we were unique still, that we were trying to be an international affiliate ITTC. I think Ukraine was already one by this time. And so this is where the first part of the process, and with budgets and revised documents, we carry on. So meanwhile, I think the whole ITTC aspect, international ITTC, changed, and INL took over. If I go back to the INL took over in 2019, and envisioned the current ITTC structure. And at a systems level, they wanted to assess the levels of pattern of drug use, the implementation of UNODC and other standards, implementation of international standards of prevention, and policy making, make a consultation training at a systems level. At a service level, again, implementation of UNODC quality assurance programs, support for counseling staff to strengthen skills, that is training, monitoring and coaching, supervision, clinical support for clinical supervisors, and you know, also strengthen recovery support systems. So it has a kind of implementation, a systems, a service level agenda for the new ITTCs. And in terms of the process, we, as you all know, ICUDDR was appointed to coordinate the new ITTCs with Kim Johnson as its head. Since then, we've went back to the drawing board, drafted a new contract, and this process has taken some time. And in 2021, we sponsored the launch of the new ITTCs and signed the contract. And I think Vietnam, Ukraine, South Africa, by this time are already functioning at ITTCs. And in 2021, a few months ago, July, we started the implementation of the ITTC by starting a universal prevention curriculum training, and now we are going to sort of follow up all aspects of it from an implementation process. And this would be our first project. So mine's going to be a very short talk. In conclusion, compared to other ITTCs, as I said, NRC is a unique organization, and I think the process of the NRC becoming an ITTC from implementation to an academic institution, which is in process, might be relevant to other countries, some other countries. The ITTC objectives can be described as addressing the gaps or the missing link in delivering the NRC's objectives and completing the picture. We certainly realize that the following up of implementation, when I say the NRC, I'm talking about the entire United Arab Emirates, because the NRC is the main response center. There are other centers, other services, other organizations, but some way to link them, it's done through ISAP as well, but to link them and to follow up from a scientific perspective, implementation plus the needs to do a proper needs analysis. I think ITTC's agenda would be very much relevant, and for other countries as well. Whilst the process of formation has not been straightforward, the stages of implementation indicate that it has definitely been a worthwhile thing. The potential for the NRC ITTC to delivering for the UAE and the region is enormous. And I think at the end of the discussion, I'll probably be very happy to take questions unless people want to ask questions now. Thank you.
Thank you, Shamil. Next, I would like to welcome Dung, an associate professor in medicine, the dean of the Faculty of Public Health at the University of Medicine and Pharmacy at Ho Chi Minh City, and Tuong, the coordinator, HIV Addiction Technology Transfer Center, ITTC, at the University of Medicine and Pharmacy, Ho Chi Minh City, Vietnam. And they will be discussing the ITTC in Vietnam.
Okay, thank you very much, Jessica, and I'm very happy and very and very honored to be to present our center to all of you. Okay, today I would like to talk about the application of our ITTC. Our ITTC is somehow special. It's not American ITTC, but it's the V-ITTC. The V is the stand for Vietnam, and H means for HIV. And it's based in our university, the University of Medicine Pharmacy of Ho Chi Minh City. Therefore, you can see the abbreviation UMP V-ITTC. And we would like to present the adaptation of our center to support the SUD and SIV workforce during the COVID-19 pandemic in Vietnam. And so first, I would like to talk about our UMP V-ITTC, and then we would like to introduce you what we will do in the COVID time, when we had a lockdown, when we had outbreak. And first, we will present the topics trained during the COVID time, and then we use the virtual model for adaptation during the COVID time. And finally, we'd like to talk about the lesson learned. I think it's not a very impressive presentation, because it's the only show our adaptation, our effort in this time. But I hope that it will be the inspiration that we are trying our best during the difficult time to continue to our effort. First, I would like to say about the South Vietnam HIV Addiction Technology Transfer Center at the V-ITTC. And why we call it the V-ITTC, and because we learned from the model from the ITTC of the US. And this is the university-based center focused in HIV and addiction and the prevention of the HIV Vietnam through the intensive and intensive training for both in-service and the pre-service manpower. In HIV epidemic in different countries, different with have a different transmission. In Vietnam, the most transmission route is the bloodstream transmission. That's via the IUD, that's mean the drug intravenous drug user, and by this and very high prevalence of HIV among the IUD, and to contain the HIV infection in Vietnam, and the government try the effort first and to have the enforce the treatment, the drug treatment, by put them in the institution, but then they can have now they had the methadone replacement treatment, and so they would like to learn some model from the US and to Vietnam, and to how to train people on how to use train the people how to optimize the methadone treatment in Vietnam. So that is why we had our university has been selected as one of two universities in Vietnam, and to training about addiction treatment and focus in HIV. And because we would like to learn from the US model, and then therefore our government also apply for the fund from SAMHSA PEPFAR with the technical support from the University of California at Los Angeles, and we officially started the operation in October 2014, and we end in 2020. But although the support from US has been stopped, but we try to get try to find the fund by ourselves by doing some training, by doing some research, and also we can get some funded by the ITTC via Hanoi Medical University in 2020. And during our activities, we start to do the eco distance learning in 2017. And first, I would like to say about our mission. The first mission is we would like to introduce, transfers, and accelerate the adaptation and implementation of the evidence-based addiction treatment and recovery-oriented services. Accordingly, contribute to improve the services quality, facilitate limitation of substance abuse and HIV epidemic. And that means we had implementation of the service, and also we would like to improve the quality of the service. And the second mission is by how we can do that, and by this mission too, that we heighten the awareness, knowledge, and skill of the workforce that address the need of the people with SUD and other behavioral health problems. And also because we would like to have the systematic transformation. So we would like to act like a bridge to foster alliance among the practitioner, researcher, policy maker, funder, and the recovery community. And because we would like to train the workforce, raising their awareness, aptitude, and the skill. And the workforce in the clinic, hospital, and treatment intervention center, including doctors, consultants, pharmacists, case managers, peer coordinators, are the key, the one who benefit most from our training. And then they serve for the patient, the family, and the community. And that is also because we focus not only in the in-service training, but also pre-service training. And also our activities also benefit for students and university experts. And at the mission 3, we would like to create our alliance for the transformation of the drug treatment program. And so we also target on the policymaker officer from local and national authority agency. And by this, we can see that the one who benefit from us, and here we had our direct beneficiary is someone who are in the service staff who work directly with SU and HC patient. And we had a pre-service staff, that means the student, researcher, and lecturer, and finally the policymaker. And for someone who is a service staff, first we do the technical assistance, and by case discussion, we visit some clinic and we help them to solve the difficult case. We discuss with the case presentation, and we had a practicum for the skill building. And during that, we also systematically find a needs assessment. We do needs assessment, and we implementing intervention by conducting the course to introduce knowledge and provide information. Parallel to this, and we also develop and introducing material, guidance, tool, and approaches, so that we can help them even we cannot go work directly with them. And also that is the one we would like to also enjoy to the IDU-CCR, because we know and we use the universal treatment curriculum and to train the student, and so that we integrating addiction medicine to the curriculum of the student of public health and student of medicine of the School of Medicine. And we support the student with the graduation on the thesis on addiction. For the master student and the bachelor student, at the end of the program, and they are required to do research project. And if they would like to do the research project on addiction, on how to relating to addiction, we have advisor to help them. And finally, we have two students. We are awareness tracing of addiction and HIV among students, and hopefully they get the aspiration to become a specialist in HIV and specialist in the drug medicine, addiction medicine. And for the policymaker, and they account about 15%, about 20% of our effort. And we invite them to attending the policy development discussion, and also the technical consulting and recommendation from policymaker. We make the bridge with them. So when they have the new policy, and some people in the working workforce cannot understand very well, and so we can convey the policy to the workforce. And also when the workforce would like to raise some difficulties and to propose the new policy, or they find the policy has some difficulty for them, and we make the discussion, and so we can have the policy discussion between the working people and also the policymaker. With this, and you can see that we have a link with the other institution, and because we work direct, our mission mostly to improve the addiction problem in Vietnam, to improve to reduce the HIV infection in Vietnam, and therefore we work directly with V-ITTC. That means the Vietnam Administration of the AIDS Control belong to the Ministry of Health, and for the other UN organization, we work directly with the UNODC. And in Vietnam, we work with some community-based organizations like the SCDI, like the G3VN, Aloboy Life. That is some community-based organization. And obviously, because we focus on HIV, we work with some the US and federal institution from the US, like the CDC, SAMHSA, and the PEPFAR program. And we link with other university in Vietnam, the University of Medicine, and also the School for Social Work in Vietnam, and to improve. And so briefly, we would like to briefly present what we have done so far. And because we work like, that is the partner, we have the partner like this, about 43 partners domestically and also internationally. And we had a link with the 55 provinces among the 83 provinces in Vietnam, and we train people there. And we have around 11,000 attendance to our event or training course, and we organize 458 events of the training, monitoring, and technical assistance. And you know that we have the resource like booklet, leaflet, video, guidance, and training material, about 260 resources like this. And obviously, it's the own effort relating to the drug abuse, about ATS, the method prevention treatment, about assist to screening the drug abuse, and then there's some relating problem like HIV and some the transgender women, etc., MSM. So that is we have the total now in 43 protocol and agenda, 28 left list, and 60 books, 115 video lecturer, and 10 screening web, and 174 presentation. That is what we have, that is resource we have developed so far. So now I would like to talk to you about because the COVID-19. And so before that, we have very the lively discussion. We had a very wonderful workshop, and we can see the people from different provinces in Vietnam, and we can also see the people from the other country and from the US, like in the conference in our university. But the time has gone, and we go to the COVID, and we need to adapt to the situation. We use the distance learning program to support the ICUDDR workforce. And so I would like to say that is what we would like to now. We would like to do so far. We have some activity. It's not as lively or interesting like before, but it is very interesting. We have the link with 55 provinces, and we had nearly 5,000 attendees in 95 sessions. And what we train for in this time, and first we pay attention to the COVID-19 because it's a very hot topic now. We say about prevention and quarantine, isolation, and guidelines, especially how to run the method clinic treatment in the time of COVID. And also there's some problem relating to COVID, like the mental health and harm reduction and overdose prevention during the epidemics. And besides that, and we continue to do some routine topics, like we focus on the drug and the chemsex. And chemsex is the new phenomena in Vietnam relating to some minority sect group, and then therefore the very increasing prevalence of the STD among the drug user, and also heroin, marijuana, and also the synthetic marijuana and substance sex, and also some mental health problem like the co-offering disorder, anxiety, depression, etc. With this, we provide some training on the intervention, and we train them on, especially for the heroin treatment. We used to use the methadone replacement treatment, but for methamphetamine we need another tool, another intervention. So we train on the counseling and specific therapy like the motivational interviewing, the matrix model, and EMDR therapy, and the mindfulness meditation, etc. That is what we are doing outreach in our distance learning, and we have covered 55 over 62 provinces, and we had a link with the 105 hospital and 43 university. And most of the majority of activity is focused in the south of Vietnam, and because we are university also in the south Vietnam. And this is the outreach distance learning by sector. First, and we have the public and private sector. That is very, very proud, because usually we used to work only to the public sector only, and we have some activities with we organize the training with the Ministry of Health and other institutions like university and hospital, and the Ministry of Labor and Ability and Social Affairs, and finally, and the Ministry of Public Security. And for private, and we work with some NGO, some community-based organization, and a faith-based organization, etc. And so that is now I would like to say about our model to doing this. And you know that for the direct training, and it's very easy. But for the online training become interesting is a lot of the initiative and a lot of effort. And first, we need to connect with the audience. We find you can imagine we use the Facebook, we use some the YouTube, and we use some email, and we use the website, etc. And we can the monkey survey. And by doing this, we know that we make the needs assessment, and we also to make announcement about what we are training. And then we organize the training, and we publish the program in our website. This is our website, ITTC. And also we, for example, on this month, we talk about the methadone clinic management strategy during the COVID-19. And we invite the one professor from the Michigan University and to present to us about the experience from the US. And this is about, for example, the topic link. This is about the link between COVID-19 and the methadone treatment. And this is about how do you know about COVID prevention and vaccine, etc. And to show you. And then when we have registration, and we make it available to the own participant by we put it in the YouTube, and you can see it very easy. We have a rich number of YouTube. And so now we can. This is how we transition to virtual platform during outbreak. And here we had I tell you what, and this is the this is the own of the virtual platform from the whole 3 years. Okay, but you can see that here only is from this is the blue one, but the green one is just in the 3 months from the March 2020 and from the May 2021 to July 21, but we can have a lot of the virtual activities compared for before. That means we have need to rely a lot on the virtual platform so far. This is number you can see that is during this is the two periods when we had a lockdown in our city, and this is the event and this webinar who attend, and the number of visit the website and number of the resource developed in this time. I would like to say you this is about the brochure by the V-ITTC and during the COVID during ITTC. The brochure, for example, how to keep safe in the outbreak or in the lockdown in the epidemic of COVID-19, and especially to address for the drug user and the patient, the people on the drug treatment and using buprenorphine. And this is some example on how the mental health problem, and also and how to care about yourself in the public emergency situation. And that is what we do before we are doing in the training, and that is follow up after the training. And this is feedback from the attendee, and most of them they can see the very useful and satisfied. Although we need to improve more, because we can see that some about 4% here they find used it and satisfied, but most they find it useful and satisfied. And 92% they say that they will recommend the course to the colleagues, and 90% they find the information gain from the training. It's very clear to all of you, but to reinforce what you are understanding and to reinforce what you are doing, we can say that the benefit of distance learning, we can reduce the time for everyone for participation of travel. We reduce the procedure burden. We reduce the expense of the transportation, renting of the conference room, and energy effort. But it can improve, address the need in the pandemic, the COVID pandemic. The need is a lot of new needs, especially to the psychological problem, to the depression, etc., and the prevention of the new infection. We improve the coverage, number of participants, and diversity speaker. Not very easy to invite the international speaker to come to Vietnam, but with the virtual platform, we can invite several international speakers to present very interesting topic in Vietnam, and we had diversity of the topic. So finally, I would like to say that lesson learned. So that the first lesson, and we learn from our experience that we need to pay attention to the needs of participants. When we first do some training, and we think it's interesting, but we do not need to have the need assessment very careful, and they find it's not appropriate, and the participation is not so good. And after that, after getting some feedback, we very careful in choosing the topics, and we can get the more popular, not the first lesson. And second, and we need to combine the training and the technical assistance in the session to optimize outcome. When we do the training, we had a didactic presentation. It's very boring. It's informative, but some boring to someone, and they can have time to real understanding the new knowledge. When we had a training and we had a Q&A session, and we saw directly some problem from the participant, and the presentation is much, the session is more, is more interactive, and a lot of the participants find it very useful for them, and that is lesson number 2. Lesson number 3 is that the people, Vietnamese people there, we are very keen to have the international speaker. I hope that after my presentation, and I can get the connection with some of you, so we can give the presentation to Vietnamese people. And we love, because we would like to see another public state, not only in Vietnam, and also we can diversify the public and broaden the new knowledge. And although some experience cannot apply directly to Vietnam, but that can open our mind, and I think we think very interesting. And finally, we think there's the continuously update and training material. COVID is emerging and is evolving, and therefore we need to update the training material and update and also the treatment is also evolving, and so we need also to update the manual. I think that's the end of my presentation, and thank you very much for your attention.
All right, thank you very much. Now I would like to take a few minutes that we have left to open the floor to any questions from the participants. If you haven't already submitted one, please use the Zoom chat feature to do that. I'm not seeing any right now, so to start off, do we have any last thoughts from our presenters? Guess not for now. I'm looking for questions. Not seeing anything. So do any of you have anything that you'd like to add before we wrap up?
Oh, just it's a question to Vietnam and Ukraine. It's nice to be part of a network with you guys who have a track record and experience. And the impact of COVID on the work you do, if you have any thoughts. I mean, it's interesting to see how Vietnam has adapted to this. When in UAE, when we wanted to start the UPC training, we kept on delaying, saying that we will wait for the world to open up, and finally we decided to go ahead with online training, simply because we wanted participants, because this was the first time that the UPC was being used, we wanted the participants to meet each other and build a real network. And unfortunately, we've kind of had to do the training virtually, and we are trying now through our using a research and evaluation process to keep in touch with them all the time. So we have following them up every 3 months and talking about implementation, but adapting to this new world when you have already had a history or a whole, years of working in this way. So, I just want to know what your thoughts about that.
I can say that for Ukraine, it's actually the same. We also moved to online format of all activities this year. We also waited quite a lot of time to postpone the activities, hoping that we will have a chance to make them offline. But now most of our trainings and workshops are held online, but we increased time for supervisions and technical assistance after the trainings. And also we increased a number of contacts after the training with our participants, in order to get in touch, and maybe for the next trainings we will have possibility to meet them face by face.
Okay, thank you very much. Dr. Shamil Wanigaratne for asking us the question. And we think that having the direct and interactive training is very useful, and we love to do that. But in Vietnam, the government is very strict on the COVID-19 containment, and they not allow. They have they would like to eliminate the COVID cases, the COVID transmission. So they do not tolerate to any contact during the outbreak, and therefore with that we are trying to improve, to open up the new way of the training. I don't think it's a successful is the direct contact, but it can open the new way, and we hope that even after we can end the pandemic, we can continue some online training, and we apply the new the new lesson here to the future. Thank you.
All right, so we are a little bit past time. See if we can quickly answer one question before we wrap up. It is, what do you see as the most unique aspect of ITTC's work? It's just for all of you.
Dr. Shamil, will you go first?
I would say that it kind of completes the picture of kind of training, research, implementation. I think it goes the full cycle, and I think in many countries there are gaps that one lot is doing the training. There is no connection between all of it to have a loop, and I think that is the unique feature, as I see it, and of the ITTC.
I think that's with the ITTC we can very interesting, because with the ITTC we can have open up. We can solve more problem. We can solve more problem than before. We can think that's how we can do the research, and we can transform the research, and especially we can have a dialogue with the policymaker. We think it's the most valuable from our activities.
And I can add that it is technology transfer by itself, because we are not limited but by only one training activity, but also we provide further technical assistance and support in order to be sure that the new technology or new practice is implemented effectively, and we support the implementation. And in this way, we close the gap between science and practice.
All right, well, that is all the time we have for today. So I just want to say a big thank you to our presenters as well as all of our participants. We have another session starting soon, so please enjoy the rest of the conference. Thank you.
Thank you.